Uh, like to welcome Sergeant Commander Rohit Verma, who is an alumnus of the Armed Forces Medical College, Pune, Institute of Naval Medicine, Mumbai. He's a marine medicine specialist at INHS Ashwini at the Naval Hospital in Mumbai. The specialty deals with hyperbaric oxygen therapy and occupational health of divers and submariners. He has nearly 20 years of experience in the specialty. He has served in various capacities on the Navy's submarine rescue ship, at the Diving Training Institute, and at Ashwini. His areas of interest are scientific application of HBOT, decompression sickness and saturation diving, and digital health. He has authored 25 papers in national and international journals and has presented at numerous conferences. He has supervised the deepest dive in India. He has been secretary of the Marine Medical Society and the technical editor of its journal. He is also an avid bird watcher and a watercolor artist. Thank you, Dr. Rohit Verma, for gracing us with your presence and teaching us something that we know very little about. Thank you. Yeah. Uh, yeah. Shall we dim the light required?
No, I think it's fine. It's fine.
Okay, great.
Chair. Chair. So, good evening, everyone. I'm Dr. Rohit Verma, and very kind introduced by Dr. Jafar. Before I begin, I must place on record my appreciation to the ENT department and Saifee Hospital for calling us here and sharing whatever expertise or understanding we have about this field with you all. I bring greetings from my hospital, which is the Naval Hospital in Bombay, which is INHS Ashwini. And I bring greetings from my HOD, Dr. C.S. Mohanty, who, because of a prior commitment, could not attend today. So we will be dealing with hyperbaric oxygen therapy in otorhinolaryngology. And we will see, my attempt will be to give a broad overview because we can't deal with too many specifics. And I'll be looking at cues from you all regarding which specific areas or which specific issues you want to dwell on further. And then we will tackle as far as possible. So firstly, we will deal with the definition of hyperbaric oxygen therapy, a very, very brief overview of the mechanism of action, the various broad indications in which it has been used, some of the ENT indications and the emerging, what we call as emerging indications, but they are like less evidences there. A couple of illustrative cases, I wish I could have done a better job with those, but that's what they have. And regarding the delivery of hyperbaric oxygen therapy, and as a hospital, if you wish to refer a patient for hyperbaric oxygen therapy, how should you go about it? The definition of hyperbaric oxygen therapy is very varied, and there are different types of definitions which are being applied all across the world. So we go by what is called as the Undersea and the Hyperbaric Medical Society, UHMS, which is based in US, which is sort of the global consensus maker in the field. And I will not dwell on the real exact definition, technical definition. It dwells on four main things.
I'll do that.
Yeah. So it dwells on four main things. And I would like all of you to pay attention to these four aspects, because these are the things which are, so to say, violated, or these are not adhered to so many times. And that's how we get the reputation of HBOT the way it is, which is sometimes not very favorable. So the first thing, what a hyperbaric oxygen therapy should do is that it should provide 100% oxygen, and oxygen which should have more than 99% purity. So just to dwell on this point, the medical grade oxygen that we get in our hospitals is 95% pure. But because we are dealing with high pressure, the oxygen which is delivered for hyperbaric oxygen therapy needs to be of a higher purity, which is 99%. Secondly, it should be delivered at a pressure at 2 atmospheres absolute. Now, that's just a fancy way of saying that, which is the twice the usual pressure at which we are there at sea level. So it should not be less than 2 atmospheres absolute. The various institutes and various centers, they give at various pressures. We in Ashwini give at 2.4 as recommended by UHMS. So why I am emphasizing this point is that there are certain centers which give air, not 100% oxygen, which give at pressure far lesser than 2 atmospheres absolute. And those are not therapeutic. Those do not achieve the therapeutic effect or the physiological effect what hyperbaric oxygen therapy is supposed to achieve. The third thing is that it should be given inside a chamber while the patient is entirely inside a chamber. So again, it sounds a bit strange for me to emphasize this point. This is because there is something called as a local HBOT, in which a part of the body, maybe a leg or something, is pressurized and given 100% oxygen. That is not considered as hyperbaric oxygen therapy. That is not considered as a scientific way of delivering HBOT. So the patient should be compressed inside a chamber, and those chambers should meet certain standards, which are ASME and NFPA, which are beyond the scope of this particular presentation. So the fourth thing is that there are a lot of haywire around the board referrals for HBOT, right from physiotherapists, Ayurvedic people, lay persons, and practically every person who has read something on the internet about something, right from hair loss to skin whitening to a variety of conditions, they are giving HBOT. So as per UHMS, at least in the United States of America, it is not considered HBOT unless it has got a physician's prescription. So it has to be prescribed by a physician. So just to re-emphasize these 4 points, it should be 100% oxygen of 99% purity, at least 99% purity. It should not be a pressure less than 2 atmospheres absolute. It can be higher, and there are various regimes which I'm not going to dwell on. It should be given while the patient is entirely inside the chamber, not to a particular part of the body, and it should be under the physician's prescription. Coming to the mechanism of action, so primarily the hyperbaric oxygen therapy is hypothesized in a variety of ways to exert its mechanism of action. And if you read lay literature or on YouTube videos, or sometimes even in scientific literature, you will find a lot of mechanisms which are bandied about or which are thrown, which are not really proven. So what I would like to for you to pay attention to is that these are more or less the 6 types of mechanism of action which have been broadly proven to be scientifically correct. So the first is hyperoxygenation. It's well understood that when you are giving oxygen at a higher pressure, there is greater dissolution of oxygen in the plasma. As we all know, the hemoglobin on the arterial side is as such 97 to 97.5% saturated with oxygen. So there is no further scope of oxygen carriage by means of hemoglobin. So what hyperbaric oxygen therapy is trying to achieve is delivery of oxygen by dissolving more amount of oxygen because of greater pressure in the plasma. So it is proved by experiments in animal models that once an individual is given about 3 atmospheres, which is significantly higher than what I mentioned earlier, the oxygen requirement of the body of the vital organs is met entirely by the dissolved oxygen in the plasma, and the oxygen which is carried by hemoglobin is not utilized for oxygenation. So this is just to emphasize the point that hyperoxygenation is the main mechanism of action for hyperbaric oxygen therapy, which is by enhancing the dissolution in plasma. The second thing is vasoconstriction, which has been demonstrated widely. So the vasoconstriction mechanism of action is varied. It is some of it is by abolition of the effect of nitric oxide synthase. Some of it is because the body's requirement in the healthier tissue is being met by the dissolved plasma only. So there is some degree of refractory physiological vasoconstriction. So, but this vasoconstriction is not there in the wound or in the affected tissue or in the injured tissue, so to say. So that is a second effect, and that helps in reduction in edema in majority of the wounds which we treat. The third is fibroblast proliferation. Now, this is an important step, as we all understand, in the healing, in any wound healing. So this is an oxygen dependent step, and in majority of the so-called problem wounds, the problem is that the fibroblast proliferation and laying down of the collagen, which is linked with the fibroblast, is hampered because the oxygen partial pressure at the site is not what it should be. So hyperbaric oxygen therapy improves that, and that it helps in fibroblast proliferation and collagen cross-linking, which then helps in wound healing. Then the fourth mechanism of action is the reactive oxygen species. So we all know that oxygen creates reactive oxygen species, which are utilized by the body, by the polymorphonucleosides to exert their antimicrobial action. So when oxygen is given at a higher pressure, the rate of production of the reactive oxygen species increases quite a lot, and that directly affects the aerobic bacteria. That directly affects the anaerobic bacteria, which do not have the scavenging mechanisms for reactive oxygen species. The next mechanism is neovascularization. So this is known to occur because of what is called as the hyperoxic hypoxic paradox. So because with hyperbaric oxygen therapy, the oxygen partial pressure increases selectively in the areas where there is a wound, and then it suddenly drops at the so-called ischemic center of the wound, because perhaps there even the plasma is unable to reach. So the oxygen gradient is made more acute because of hyperbaric oxygen therapy, and this acute oxygen gradient then helps in neurovascularization. And finally, it is hyperbaric oxygen therapy is acts synergistically with certain class of antimicrobials. So the indications for hyperbaric oxygen therapy are given. Again, I'm sticking with Undersea and Hyperbaric Medical Society. So it is given last time. This was done in 2022. So I think the 15th edition is due now, or it has already come. So basically, it says that there are about 14 odd indications for which hyperbaric oxygen therapy is useful. Now, I would like to emphasize here that majority of these indications, the hyperbaric oxygen therapy is an adjunctive treatment. It is not the primary treatment. So whenever we are talking about HBOT being helpful in this indication or that indication, it has to be understood that it is always works well. It always works with the primary treatment. It's not that only primarily hyperbaric oxygen therapy will be able to treat the patient. So there are some absolute indications like carbon monoxide poisoning, gas embolism, decompression sickness, Clostridial necrosis, and necrotizing soft tissue infections. These HBOT is an absolute indication, so to say, that there is a conclusive evidence and it has to be provided urgently. Now, as you would see this list, majority of them we do not encounter in our clinical practice. So carbon monoxide poisoning, gas embolism, decompression sickness. So all this, of course, Clostridial myonecrosis and necrotizing soft tissue infections are encountered, but then they are also amenable to treatment by other means. So this is a subset in which hyperbaric oxygen therapy is proven to be beneficial. However, the incidence is, as is apparent, is not much. In second group is that in which it is strongly established. So radiation tissue damage, chronic refractory osteomyelitis, diabetic foot ulcers, and thermal burns. So this is which we see maximum. At least in our center, our maximum load is for the radiation tissue damage, primarily coming from the Tata Memorial Hospital and our own hospital as well, and other centers. So here we see that HBOT is significantly useful. And in idiopathic sudden sensory neural hearing loss, we will be talking about it shortly. and enhancement of selected problem wounds. It's conditional or adjunctive. Now, this green one, investigation or off-label use, is the ones which are maximum advertised and in fact have the lowest evidence. And in fact, in so many places, it is a contraindication also. For example, in autism spectrum disorder, in multiple sclerosis, now the evidence has been largely against hyperbaric oxygen therapy. Although these are the conditions for which there is no other conclusive therapy available also. So people tend to give hyperbaric oxygen therapy in the belief that if nothing else works, at least let us try this also if it might work. But as on date, post-concussion syndrome, autism spectrum disorder, multiple sclerosis, cerebral palsy, at least in autism spectrum disorder, multiple sclerosis and cerebral palsy, it is definitely the various evidences HBOT should not be given. At our center, about 10-12 years back, we were trying it out, but as on date, we are actively refusing any referrals which are coming up for these indications. As for fibromyalgia, we tend to take one odd, and my understanding is that there are other centers in India, one in Godrej Hospital here in Vikhroli, and another one in Trivandrum. So they have had some positive results with fibromyalgia. We will be shortly taking up a case, but evidence is still not there. And long COVID has been tried because like so many things have been tried for long COVID. So HBOT has also been tried. So what I would like to emphasize again in this chart is that these central ones, yellow and orange and blue, this is what if you have any of these, if you encounter HBOT, can be a useful adjunct. It can swing the way towards healing. What about migraine? Do you get lot of patients? Yeah, so migraine has been tried, but again, evidence is not there. We also have tried migraine one odd about a couple of years back, and our experience of what I can, since there is the scientific evidence is not there, what I can fall back on is my experience, which is, I mean, our center's experience, which is not very encouraging. So in this list, I think I would not say other than maybe post-concussion syndrome. So if there is a diffuse axonal injury, we have had some encouraging results in diffuse axonal injury post-concussion syndromes. But again, it is variable. So coming to ENT, so this strong, moderate, or low investigational is what I must emphasize again, that HBOT as a technique is very difficult to achieve a RCT, randomized control trial. And whatever evidence which we have is usually of low quality. So if you go to Cochrane and try to find out any HBOT indications, the first line is that the evidence is either very not there or it is of low quality. That is because of the peculiarity of the treatment, that you cannot actually achieve blinding, that randomization is also an issue. So, and control is of course a big issue. So the number of RCTs are much lesser than in other therapies. So this, when I'm saying strong evidence or moderate or low, it is based on whatever best available evidence is available. So in idiopathic sudden sensory neural hearing loss, there is a strong evidence. Although there is a debate within our hospital also, and in the literature also, that when to give it, so that I'll be dealing slightly later. Again, radiation-induced injury, whether it is bone or soft tissue, we have seen good results in our center also, and internationally on evidence also, there is a very good result. Post-operative wound healing, flaps and grafts, particularly in selected patients, diabetic patients or immunocompromised patients, or patients with poor nutritional status, or otherwise, or maybe irradiated patients. So here, not in all post-op wounds, not in all flaps or grafts, but in selected patients, HBOT has been a game changer, and that we have seen very, very clearly in our center. And of course, the evidence is again very sketchy internationally. And this we have also, since I think I'm speaking primarily to an ENT audience, so the head and neck wounds and head and neck flaps, again, we have got encouraging results. As far as moderate is concerned, because the conditions are I mean, not very frequent. So Mucor, it was tried very sporadically in the aftermath of the COVID, when there was a sudden spike in Mucor. And again, there was mixed results. Our own experience in our hospital with Mucor is that we have saved at least couple of lives in Mucor, but then we have lost also. So it is again variable. It depends on the patient factors and everything. So the learning here, why is there at least with Mucor, is that if you refer early, I mean, with Mucor, one must understand the faster one does the intervention, the better the chances are. Idiopathic tinnitus has been mentioned in literature. We do not have much experience with this, so I'm not on it. Malignant Sarna, my ENT colleague was just telling me in December we had one MRSA positive and quite a difficult patient. And that one patient we had a tremendous improvement in that patient. And the literature is again very sketchy, mostly level 4, level 3 investigations. These list chronic rhinosinusitis is again low and investigation. Bell's palsy is something that we are doing in Ashwini very energetically because we have got some good results. And we are trying to gather the evidence. As on date, we have 23 in last couple of years, and in about 1.5 years, 1.5 odd years, we have got about 23, and we have got good results. So that will be, I think by the end of this year, we should see it getting published. So Bell's palsy is something. Can I ask you a question? Yeah, please go. Bell's palsy, 98% of them will recover without treatment in 9 months. Exactly. So, your patients not receiving any treatment?
Is it the people who've not responded to steroids?
Okay, so I will deal it in two parts. So number one, as I emphasized earlier, the standard treatment is always there. This is an adjunctive, and as Dr. Jaffer said, that it's a spontaneously recovering illness over a period of months, maybe a few months. So here, what we are seeing is that the lag ophthalmos, the eye symptoms, they are recovering within about 6 to 10 days, which is taking about, and as all of you will know it much better than me, the eye symptoms are the ones which are the most problematic because of the drying up of cornea and other issues. So we are able to achieve complete eye closure in a lot of patients. I mean, it will not be correct for me to put a statistical number to it, but in our experience, the lag ophthalmos which we have seen is improving in just about 10 days or maybe.
What is the grade of the lag ophthalmos? Is the grade 5 palsy that you're treating and it becomes grade 1? Or is it like a grade 2 gets becoming grade 1?
So the higher grades are coming down to lower grades, and the lower grades are recovering completely. Okay. So that is what we are, the House-Brackman criteria that we are.
You are giving the steroids.
Actually, what happens if the person in different setup, if the person he doesn't have any comorbidity, then if we are giving HBOT, in that mostly in 6 days to 7 days, means 6 days, we can see that leg of thyroid is recovering. Be better. Recovery is very fast, and if they don't have any comorbidities, they can almost.
So to come back to what Dr. Jaffar's point, so lag ophthalmos does improve over spontaneously also with the standard therapy. But the time period is what we have seen is reduced. Now, whether that is statistically this thing or not, that we will see a few more cases and then perhaps. But what I can share is that our experience at the center has been early recovery with Bell's palsy, and mostly when the HBOT has been started within the first week. So there are now we have a protocol in which all our peripheral hospitals, say from Goa or let's say from Pune and other places also, from where we usually get our patients. So they are referring to us in when they get a Bell's palsy, they are referring to us and early. So as soon as possible. So by about end of first week, we are able to give. If it is beyond 10 days or beyond 2 weeks, excuse me. If it is beyond 2 weeks, then our results are of course not that good. Or if there are or if there are comorbidities. So like we had a doctor who was a diabetic, and then he had a recurrent Bell's palsy over 2 episodes, and then that I am again coming back later in a later slide. So if there is no comorbidity, like what my colleague mentioned, that the individual is otherwise healthy and having Bell's palsy, then we are getting a faster result and good result. But if there is any comorbidity like diabetes or some other this thing, then not so much. So that we are still trying to analyze, but that has been more or less broadly our experience. So now we have a protocol in place. So we are energetically looking for patients and trying to see where we reach, and if what we are trying to see if it is correct or not. I mean, it can go other way, as as it has been brought out that it is spontaneously recovering also.
What about malignant otitis externa? When do you start?
So, sir, as we haven't had too many cases. So we started in this case about I think 3 odd weeks after the onset. So this was like actually what I would be very honest with you. Like in any other clinical setup, once everything else is exhausted and the patient is not doing good, then they think of hyperbaric oxygen therapy also. So I mean, so for this moderate low investigation things, so this was again such a case. So we had couple in last 2 years, not too many. I mean, 2 cases are, but we had good results, and this was almost I think well into the third week.
And how long do you continue?
So in any case, I'll be dealing with it subsequently also. But
No issue.
but just to answer your questions, in any case, this is not a therapy which will have its effect in 1 or 2 or 3. So typically, any condition requires about 20 odd sessions, 20. So till then, you can say that. So like if I'm talking about Bell's palsy, by the 6th, 7th, or maybe about the 10th day, we are able to see a significant improvement. And then it tends to consolidate over the next 10 odd days, and then it seems to plateau off by about 20 odd. So that is more or less a number which we can put, that if you are thinking of referring a patient, I mean, you should be looking at around 20 odd days of therapy.
It's given on daily basis.
It's given daily basis. In case it is a serious condition like necrotizing fasciitis or carbon monoxide poisoning, then we give it multiple times a day. I mean, twice also. So like in this malignant otitis externa, if I'm not wrong, I think initially we gave him twice a day for about 2-3 days. 3 days we gave him twice a day. So
And how long is that change?
okay, so I think I'll deal with it right now because that is the logical question. So typically the session is lasting from 60 to 90 minutes. That is the standard. That is the protocol which various centers follow. We in Ashwini follow 90 minutes. So 2.4 atmospheres, what I mentioned earlier. So it's nearly 2.5 times the pressure at which we are there for about 90 minutes. And in between we have a break. Break in the sense that the patient is breathing through a mask, and then the mask is removed for about 5 minutes, basically to decrease the effects of oxygen, likely effects of oxygen toxicity. And the entire procedure, I mean, putting the patient inside the chamber and then achieving this, because it's not like a button, so it takes some about 10 to 15, 10 to 12 minutes to reach this 2.4 atmospheres absolute pressure, and the same time to decompress also. So overall, we are looking at about 2 hours of intervention. I mean, right from the patient that he walks into the department till he walks off the department is about, we are looking at about 2 hours. And there are some conditions in which it is longer also, but then that is beyond, I mean, for diving indications and all. So we give much longer. And in certain cases, what we have seen is that patients are, so initially what we do is, there are certain more, if the patient is moribund or is not very stable, then we try to give a shorter session to see if the individual is able to tolerate HBOT or not. Now, one thing I would like to emphasize here is that inside the chamber, when the patient is receiving HBOT, not much critical care or not much intervention is possible. Now, that is because the monitoring is limited. You can't take a standard monitor or an infusion pump or a ventilator inside the chamber. So in fact, not even watches, mobiles, iPads, nothing. I mean, anything which has got more than 8-volt battery is not supposed to go inside, and anything which can create a static electricity. So monitoring inside the chamber is a challenge. That is number one. And number two, the space is a bit of a constraint. And typically we have only one paramedic inside. I mean, we have one paramedic and about 5 odd patients inside. So typically any sort of intervention inside the chamber for a very critical patient is not possible. So we only take patients whom we can see that if he is able to sustain for about 2 hours without active monitoring and active intervention. So we have to disconnect all the lines, I mean, clamp all the lines, and we have to, only then we are ready to take it. Because if there is an emergency inside the chamber, we have to wait at least fastest maybe about 7 to 10 minutes for the chamber to be decompressed and the individual to be wheeled out. So that is a major limitation. Now we have got some degree of monitoring. The monitor is outside, but the probes, the sensors are inside, because so with that we are able to achieve some degree of
And are they able to tolerate patients are compliant? Are they able to stay in that chamber? Or do they feel anything with the change in pressure?
So I think that's a very interesting question. In about last 20 years, I have had one patient, a girl who got crush injury, girl who absolutely refused to go inside, and she was just screaming, and we just couldn't. So in about maybe last 20 years, one such patient. Other patients are apprehensive, but we have got a good team and we have got very professional residents who keep a tab on them, and they explain the procedure. And it is interesting to see after second or third session, they would really want to go. And even when we want to discontinue, because it has got a very big placebo effect. So, I mean, that is documented also, that you are being made to go inside a chamber and then it is pressurized. And so it's not like a usual medical procedure. It's not like, I mean, it looks like something like an MRI machine, but slightly less claustrophobic. And so what we have seen is that initially the patients do have some degree of apprehension, but over a period of time, third, fourth, fifth session, the patients are insisting. There are patients who will coax and cajole their primary physicians to continue to refer them to us. And even when we are very clear that we have achieved the plateau.
My point was that I am a trekker, so I go up high in the mountains. As you go higher, the pressure becomes less.
Correct.
So you become breathless. I
Correct.
don't know what is the opposite when the pressure is high. How does the body react to that? Is there something differently you feel?
So you don't feel anything. It's something like when you are going in an aircraft, only slightly more. So one doesn't feel any pressure or something. Only thing is that that when you are breathing 100, because it's not only pressure, it's also 100% oxygen. And we can't have oxygen leakage inside the chamber, because then it's a closed chamber, and oxygen at high pressure, we all know, is a fire hazard. So the masks that we use are very tight fitting. I mean, reasonably tight fitting, and they have what are called as demand valve. Unless the patient takes a inspiratory effort, a negative effort, it doesn't open. So I mean, it takes a small amount of inspiratory effort for that valve to open. So to prevent leakage, it's not like the normal pipe supply which we get. So that what happens is that most of the patients, they try to inhale it deeper and deeper, and that then they get tired, and that is the effect of which we visibly. So oxygen toxicity is a rarity, ma'am. It's oxygen toxicity at the level at which we are giving 2.4. Oxygen toxicity primarily is of two types. So when we're looking at the acute oxygen toxicity, which is the CNS oxygen toxicity, that usually does not happen below 2.8. So we are way below at 2.4. And in certain conditions, certain susceptible individuals, or if the patient is having certain medicines, or if he is having fever or something. So in that, the threshold is lowered, but at least in last 20 years, I have seen maybe 2 or 3 oxygen seizures, oxygen toxicity induced seizures, which are immediately stopped once you remove the mask. So once you remove the mask, it is a matter of maybe 5 to 10 seconds that the seizures stop going up. So that is there. And for pulmonary oxygen toxicity, the exposure has to be much longer, much longer. So we are just giving about 90 odd minutes in an entire day. So that becomes a concern if we are giving it more than once a day. So there like this, not this malignant otitis externa, but there was a crush injury patient whom we gave 3 times, and then next day about twice. So in that there is a demonstrable lowering of the pulmonary functions and all, but then that is reversible. So pulmonary function effects are broadly reversible, and CNS oxygen toxicity, we are way below the level. I mean, in the broad adult group. In a pediatric group, of course, they are very different. I mean, they are at a lesser threshold. So I think we'll just go to one illustrative case. So we had a 27-year-old female. So this SNHL, we have had about 15, 17 odd patients in last 1 year. So basically in this patient, there was about 48 decibel loss bilaterally. This is the average. I'm not going on to the each frequency. And she was also treated with the normal standard therapy, and she was started early. And in about 12 to 14 days, we had a complete reversal of that effect. So this was like one of our good success stories. But this is just to highlight this point. There are people who come to us maybe after a month or so, and then or like in our scenario, because of this high noise induced sudden hearing loss. So if there is a like in firing and all, so we do get those, and there our result is much less spectacular. So if it is idiopathic, if it is brought to us early, we have seen complete reversal. I mean, complete recovery also. And in noise induced, I mean sudden noise induced hearing loss, we do see some benefit, but then we can't really pinpoint it on HBOT, because that would otherwise also over a period of time, as the healing takes place, it will be there. So here again, we gave about 20 odd sessions, although. So in most of the ENT conditions, if you look at chronic conditions like Bell's palsy or sensory neural hearing loss, the effect is, if you are reaching somewhere, you will come to know between 10 to 14 days. Otherwise, it's not responding. And in acute, let's say, like sir mentioned, malignant otitis externa, that you will see much earlier. If, I mean, second, third day, the patient, there are some indications that the patient is recovering. So if we are not, so we, as a matter of protocol, we insist on 20, because then we are able to compare, because we can stop earlier also, particularly in Bell's palsy, because there are patients who are not recovering after about 2 weeks, 10 to 12 days also. So in those patients, we still go till 20, but we have seen our result is that a person who does not improve by maybe about the second 10th or 12th session, then he sort of plateaus off.
So in this case,
Yeah.
not doubting, but like he was already on steroids also.
Yeah.
So how are we sure that what's really helped them in these 14 days or?
Okay, so we are not sure. So we are not sure. So the short answer is we are not sure. But what even in our setup where HBOT is so accessible, not every patient gets to us. And if we can, I mean, again, I would not dare do a statistical analysis, but broadly, you can say anecdotal evidence that if we compare with the patients who have not had the benefit of HBOT, our results are, I mean, our recovery is faster. That is what I can say anecdotally. I will not say, I mean, statistically and like evidence wise. So what your point is absolutely correct. Like for example, in diffuse, so in this diffuse axonal injury and all, our neurosurgeon, he is absolutely fixed on HBOT, and the one who was previous was absolutely. So we have had need two set of individuals, two set of patients where one person did not expose to HBOT, and one set was, I'm not making a randomized control trial, but broadly in a clinical practice, what we can see is that we have seen that we have had faster recovery. Maybe the person would also recover spontaneously also, but at least what I can stick my neck out on that with HBOT it is a faster recovery. Maybe with spontaneously also he would have recovered. And the second thing, I would not stick my neck on it, but a complete recovery. Okay.
How about, have you all done this on patients who've not responded to steroids?
There are centers other than army where there is no HVAC facilities available like AFMC and the RNR hospital. So we compare the data, the patients who are going HPOT in this center with the patients who are not going HPOT. So the time period taken for the improvement, and we compare the data, studying the data. So we have seen that it, as an adjuvant, it helps in the faster recovery. But the at the end of 30 days, the recovery rate is same, but it has reduced the time of recovery of oddly 1 week, both in the best wells and the SNF. And another indication we have sent for the HBOT in the case of SNF best wells in the patients who are contraindicated for the steroid therapy, you have uncontrolled diabetes, and they are contraindicated for steroid therapy.
There
So,
we had done inter-defined injections with HBOT as a salvage. It also says that this is as a salvage. So in that case, we have.
But there also intratympanic steroids was given.
Yes.
So just HBOT.
because we can't remove the standard care of treatment.
Okay.
So it always acts as a adjuvant. We are given as an adjuvant, and we studied the data. Is it helpful in the early recovery or not? So the data which showed us there is an early recovery of 47 days when compared to the other centers.
No, my point is that
You're talking about refractory to
or to the
refractory.
standard
So
treatment.
I think we don't have any data on it, but we have generally seen that there is recovery post HBOT. Even so, if the individual is refractory to steroids, maybe after 4 weeks or so, there's hardly any improvement. With HBOT, there is an improvement. There is a distinct improvement. Now, I will not put a number or this thing to it that how much it is. Not definitely a complete recovery, but with HBOT, it is always better. So if I have to summarize with the usual caveats, I think with HBOT, it's always better. I mean, whatever. So, and as far as the point of, saying that conclusive evidence, that we don't have, that nobody has, because we can't, as I emphasize again and again, that it's an adjuvant. You can't achieve, like we get patients phase in which we were getting very poor patients, diabetic foot patients, who were so enamored of this thing, and they had such dramatic salvage of foot that they, because the anti-diabetic therapy is quite expensive, they stopped that and they started taking only this. So this is something which we, I mean, of course, something which we don't agree with, and I mean, which we ask the patient to continue with the standard care. That so we always insist that a patient who's coming to us we should continue with the standard care. We don't want to prove a point that this is because of HBOT. I mean, it's not. It cannot be. So I think this we can skip. So just to give an idea, so this is not my chamber. This is King Hamad University Hospital in Bahrain, where one of our senior colleagues is there. So he very kindly shared his photograph. Why I have not shared our chamber's photograph is we are getting a chamber, something like this installed in another. The first components have already started arriving, and by about end of August, we intend to move into something like this chamber. So I don't want to bore you with a old Navy type of chamber. So this is something called, so there are two ways in which HBOT is delivered. So this, as you can see, is a longish kind of chamber, multiple portholes. So this can seat typically about 4 to 10 patients. The one which we have, we can give 6 patients as of now. And the one which is being installed, our newer chamber, that can take 10 patients. So this is called what is called as a multi-place chamber, or sometimes called multi-person chamber also, or sometimes, and it is usually very what is the term these days, patriarchally called 10-man chamber or 6-man chamber, but it can take about 6. The other option is something which is like this. So there are 4 of these placed. So this is called a mono-place chamber, wherein only one patient can go in, and as you can see, there can be no attendant. So usually in this multi-place chamber, you have maybe 1 or 2 paramedic inside, or in case of critical patient, we do send the resident or sometimes self also. We go in, and in a mono-place chamber, as you can see, only the patient goes in, and this entire chamber is pressurized with oxygen, so it consumes a bit of oxygen, and the healthcare provider is able to see from outside, and but not much intervention is possible. Here, a bit of intervention and a bit of monitoring is possible. So this is how we monitor. So there are cameras and there are phones with which we can communicate, and the attendant inside can see all the patients, and he can talk to the patients and he can talk to the attendant. This is, I put this figure because this is how our newer chamber is going to come up 10%, and we have now hyperbaric compliant screens also. So inside what ma'am mentioned that, I mean, it would be quite boring to sit inside 90 minutes in a pressure environment. So they have got some sort of entertainment inside. So if you come up to the hospital after maybe 3 months, I can show you this around in actual. So this is the mask as what I was mentioned. There are hoods also available so that the patient is the entire hood is flooded with oxygen. So those as of now not available with us, but in the newer chamber that we will be getting. Okay. So coming to how do you refer a patient? So what I would say, I mean, I thought from ENT point of view, so radiation injuries to head and neck, grafts and flaps, idiopathic sudden sensory neural hearing loss, mucor, and Bell's palsy. If you are getting stuck with this, if you are, what I would like to emphasize is please send early. So not when you have exhausted everything, when you have seen that the corticosteroids have done nothing for 4 weeks. Because HBOT also helps, because ultimately you have to understand that it is hyperoxygenation, which is the mechanism. Once there is a limit beyond which the tissue will be able to sustain without oxygen. So the earlier you send to us, the better result will be from hyperbaric oxygen therapy. So if you are looking at radiation injuries, grafts and flaps, problem wounds, not every graft and flap, but if you are if in an immunocompromised patient or something, idiopathic sensory neural hearing loss, I think you should send all. Mucor, if the patient is in a condition to be transported to us, yes. Bell's palsy, I would say we are aggressively pushing for it. So I'm being the salesman here. So Bell's palsy, yes. And others, most welcome to discuss with us. You might, if you think that there is an ischemia, if there is an ischemia which is not being able to be corrected with your routine measures, then please think of HBOT, and you can discuss with us and we would be happy to help. Once you are planning to send, you have selected a patient, the general condition of the patient, of course, you would be assessing. It should not be a very, very moribund patient, as I explained earlier, requiring critical care. Cardiac and respiratory status, please evaluate. Typically, we don't take cardiac patients below 35% ejection fraction, although we have attempted some heroism these days because it is not recommended, because the time of response is at least 10 minutes, 10 odd minutes. Please look at other comorbidities, like ma'am mentioned, somebody might be claustrophobic. So we would evaluate. Please look at a 12-lead resting ECG and a chest X-ray PA view, and whatever condition specific investigation. So if you are having any of this, and more or less cardiac side okay patient, respi we still manage. ECG and chest X-ray more or less okay. I think we are good to go, and better early than late. So okay, this was my favorite quote: "Dulce bellum inexpertis." Nothing to do with HBOT. It means that war is sweet for those who have not experienced it. So this is a chat bot which I have made. You can take a snap of this. It is we have done some literature, and of course it pulls from the internet also. Not very reliable, but as on date, it still beats all of my residents. So you can ask it questions and if you find some discrepancies, please let me know. I'll try them. So this I have finished. If there are any further questions.
This is refer, so do other patients also.
Yeah. So we take in all patients, we take in everybody.
And
Cost.
how expensive is it?
So cost, here is the biggest, crowning glory of my center. We are setup, government setup, we do charge, but it is, I think 300, how many, what is the number? 350 rupees or something
Per session.
per session.
That's
So,
cheap.
which is about 10 times lesser, maybe 15 times lesser than a
Right.
comparable setup in private.
And
And,
3 bucks a session. And how, so you must be having quite a load.
So
Yeah,
we do
how
have a
much
load,
the
see,
waiting
we do
period?
have a load and you see our machine. So we do, as I said, 2 hours per day and around about, and we have got infected patients, we have got diabetic foot and all. So we do a thorough chamber cleaning after every session and all that. So we are not able to sustain more than 3 sessions with the current one. But with the new chamber coming up, God bless, in another 2 months time, 10, and if we are able to do 3 more, so we'll be able to take 30. So we will, as on date also, we are practically the largest center in the country, but then I can authoritatively say that we will be able to. So as on date, we do triage the patient. So radiation cystitis, proctitis, because the patient are chronic and exacerbation and remission, so we place it on low priority. Other indications, infective conditions, we take it on high priority. And so, once you talk with us, we will be able
So if
to.
at all I have referred you a patient, is there a possibility that you feel that it's not required and it won't help and you will send the patient back to me?
So I would.
If I am just randomly thinking that I want to send this patient for HPV, is there a possibility that you will tell that patient your doctor is wrong, you don't need it?
No, we don't never say that doctor is wrong. We
Or
always,
whatever.
we always speak with the referring physician as far as it's possible. It's always possible.
It's possible that the guy has got it wrong and sending a patient
So we will
which is
discuss.
not indicated.
So we will discuss, and I'm sure if you have sent a patient, you must have something in your mind. So we can always thrash it out, and it's not that we are living in a watertight compartment of those 14 investigation of some
Okay.
Gora guy sitting in US and telling us what to take. We are quite open. But what I would like to draw the line on those cerebral palsy or autism spectrum disorders, multiple sclerosis, we do take others also. We do take in which there is negative evidence also. We need to, between the patient, the referring physician, and us, we need to have some sort of an understanding what we want to achieve and how realistic it is. Even if it is remotely, even if the chance is remote, we communicate it to the patient, we are transparent and we communicate to the physician, and depending on our availability, we do take it. Other than the ones which I mentioned.
Okay.
And if there is no contraindication. So contraindications I didn't mention because there are some people who like to claim there are no contraindications. The only contraindication is an active tension pneumothorax. So I think in that condition, nobody would actually send
What
it.
about the problems that people complain with the lung fibrosis, eye issues, etc.?
So that is after a really prolonged exposure. Here we are giving 60 to 90 minutes. So whatever decrease in the lung function, which we have also observed, is completely reversible. So with 90 and 90 session once a day, it's not happening. Multiple sessions, yes, we see shortness of breath, we see dyspnea, painful breathing, but that is reversible. And we have to weigh the risks with the benefits. So if the risks are high, if the condition is which can be treated without the patient going inside the chamber, then of course we would say. But as far as those lung complications are there, the one thing which I would like to emphasize is that ear barotrauma. So that is there. So our center, other centers in India are saying 0. I think they are being less than honest. We have got about 7 to 8% ear barotrauma in this thing.
Any age criteria for this?
We usually discourage, pediatric patients below 10. I don't 10 से नीचे तो हमने कोई नहीं लिया है ना. There was a time when we used to take very young children autism spectrum disorder. So, I mean, it didn't do any benefit, but it didn't do much harm. I mean, it didn't do any harm also. So, other than pediatric, pregnant women, we don't take them because not because the results are
Reaction.
Upper age limit,
upper age limit, none.
the patient can't sit on the chair.
We will take it lying down.
Is the chamber which you showed?
Yeah, so that we have got a bed also. We have got a bed. So I mean, we will schedule it. We will. So that chamber, yeah. So that is a bit. I think.
No, that's like this.
Yes, so that's a bit misleading. So we have got a lying bed also. So in this one and here the current chamber which we have, we will be using both. So here we have got nice 2 beds on which we make that's not as comfortable and sophisticated as this one. It is just two. It's like the third AC compartment. If you have traveled, so that it looks like that. So lying patients, elderly patient. Our only issue is cardiac stability. If the patient is unstable cardiac wise, then long years back, about 25 years back, we had a fatality also on the cardiac side.
So in your experience, what is the commonest condition that you all are dealing? That is, it could be ENT, it could not be ENT. What is the commonest patient base that you all are treating?
So majority of our patients are radiation cystitis, radiation proctitis from outside because Tata is sending lots, and those are the patients who can't really afford it other places. From our own hospital, it is problem home. So diabetic foot, crush injuries, flaps and grafts, and what else? SNHL and palsy. We are now big. As I
Thought.
Yeah.
Is it palsy? Then why not a viral facial palsy?
Okay, I think we had one viral facial palsy.
When comes to the diagnosis of execution, so we can know exactly like this is a viral or pediatric.
Bell's palsy we know, right? But there is something called Ramsay-Hunt syndrome,
Yeah.
which has lesser chances of recovery than Bell's palsy.
Yeah.
So why not try it in that?
Idiopathic Bell's palsy can only be recovered by HPOP. Ramsay-Hunt syndrome, there is no literature about any of the viral.
So, but we can try. Because pathophysiology is more or less
Edema.
similar. Edema, nerve surrounding the nerve.
Right. Again, if antivirals are given, then that is also one of the things. So there is no scientific studies based on this HPOP and Ramsay-Hunt syndrome.
So, like you said, you mentioned a few minutes earlier that if you send a patient, we will send him back. So we can discuss, and I mean, Ramsay-Hunt, I think fits into that kind of.
Better than Bell's palsy.
Yeah.
Any idea of infected patients like active TB or like he said Ramsay-Hunt where you would have.
But we had MRSA positive. We had recently what we had. So we have to, I mean, look at that. So we can't take everybody inside. So for that patient, immunocompromised patients, MRSA positive, and recently we had one. What was that? Pseudomonas, and what was the other culture? There was another one. So
Yes.
multi-drug resistant organisms. So we then take him in a separate session, and then I mean,
What's your experience?
Okay.
migraine, ma'am, we have not given much. I think एक या दो को दिया, not much.
And tinnitus?
Tinnitus, I think 0. Tinnitus we haven't had.
No, you didn't have patients, or there's no.
Okay, sir. Thank you. Everybody's really thankful. Whoever's there, thank you for giving everybody a great session. I'll shut the recording now. Then we can continue our discussion.
Yeah.
End meeting for.
Right, then.